Can you hear me? Oh,
Can everyone hear me?
yes, I can hear you just now. Things went silent for a while and then, I'm hearing everyone now.
Okay. Well, welcome everyone. My name is Chanel Roberts. I'm the project manager of the AMG CME program, and I'm excited about tonight's discussion, which focuses on women's cardiovascular health. As we know, heart disease affects women differently than men, and tonight's conversation places a spotlight on its importance. It is my pleasure to introduce our renowned speakers for this evening. Let's begin with our guest speaker, Dr. Renee Bullock Palmer, who is the director of Women's Heart Center and Non-Invasive Cardiac Imaging at Deborah Heart and Lung Center, which is located about a half hour south of Trenton. Dr. Palmer is heavily involved with the American Heart Association as chair of the Women, Infants, and Children's Committee, section editor of the association's Circulation Imaging Journal, and a board member of the Southern New Jersey chapter. As I worked to pull this CME together, I learned that Dr. Palmer enjoys boxing and kickboxing to manage her stress. A woman after my own heart, because I do as well. Our homegrown team includes two incredibly talented AMG cardiologists. Dr. Bosia Liang is a cardiologist at Atlantic Health System and medical director of its Women's Heart Program, which provides gender-specific care for women with known or suspected heart disease. Under her direction, the program also provides intrapartum care to women at high cardiovascular risk. Dr. Bosia has been featured in local and national media for speaking about gender differences and disparities in heart care. Her extensive involvement in diagnosis, treatment, and clinical trials continues to produce success stories where women emerge from heart attacks and go on to lead better, healthier lives. Dr. Fishberg is a cardiologist at Associates in Cardiovascular Disease in Springfield and in Clark. He's an educator at heart and serves as an assistant clinical professor at Thomas Jefferson University's Sidney Kimmel Medical College. Dr. Fishberg is also a principal investigator for several clinical trials involving lipid disorders, his true passion, and acute coronary syndrome. When Dr. Fishberg is not seeing patients or teaching, he enjoys spending time with his lovely wife and beautiful granddaughters. And now for our clinician panelists for tonight. Dr. Jeffrey Feldman, a nephrologist in Union who specializes in care and management of patients with diabetes, lipid imbalances, hypertension, and chronic kidney disease. Dr. Feldman is an innovator in his specialty and part of a research team working closely with patients suffering from severe cardiovascular disease. Dr. Feldman is very passionate about eradicating disparities in healthcare, especially among people of color. He's active throughout AMG, from his role as chair of the lipid work group to providing his expertise on CME panels such as this one tonight. And finally, I'll say a few words about Dr. Carleen Williams, program director for the Overlook Medical Center Internal Medicine Residency Program. Dr. Williams teaches and actively mentors residents and faculty in the longitudinal quality improvement curriculum at Overlook Medical Center. She is a member of the Society of Hospital Medicine and an alumni of the 2013 Quality and Safety Educators Academy. She has also served as lead faculty mentor for the Committee of Interns and Residents, Pilot Quality Improvement Clinic, faculty for that organization's Policy Education Initiative, online quality improvement training modules. Her professional interest includes transitions of care and cultural competencies, which she also shares on medical mission trips to Haiti. I'm thrilled to have you all join us tonight. Thank you to our esteemed speakers, and thank you, Dr. Washington, our Associate Chief Medical Officer, who will join Dr. Williams to moderate the panel following the CME. Now, Dr. Palmer, would you like to kick things off? Thank you.
Great. Thank you so much for those very kind introductions. And I'd like to also thank the Atlantic Medical Group, including Dr. Fishberg, for this very exciting invitation to be a part of this program this evening and to be among this esteemed faculty. So this evening, I'll be speaking about addressing the disparities in care in the management of hypertension. I have no disclosures. So the outline of my talk, I'm going to be going through the definition of hypertension, the risk factors for hypertension in African Americans, and the I'll also be speaking on the recommended management of hypertension in this patient group. I'll also be going through the reasons for disparities in management of hypertension and outcomes. And finally, we'll be speaking on cardiovascular risks associated with hypertension in African Americans. So, with regards to the definition of hypertension, blood pressure should be categorized into four main groups, either normal, elevated, or stage 1 or 2, to prevent and to treat high blood pressure. And just what are these categories? So normal blood pressure is any blood pressure that's less than 120/80. And elevated blood pressure is between 120 and 129 systolic and less than 80 diastolic. With stage 1 hypertension, we're talking about the range of 130 to 139 systolic or 80 to 89 milliliters of mercury diastolic. And with stage 2 is anything greater than 140/90. It's very important that individuals in two categories should be designated to the higher blood pressure category, and also that the blood pressure that is measured on at least two separate careful readings on two separate occasions. So if you're seeing a patient in the clinic, this is the first time you're encountering the patient and the blood pressure is in either of these ranges, you should at least have a separate visit on a separate occasion with a blood pressure reading, and you'd like to have two of those readings. If they're elevated in either of these stages, then you've made the diagnosis of hypertension. So there are other forms of hypertension in terms of white coat hypertension, mass hypertension, and so on. And one of the things that I think is very important to do, especially when we're seeing these patients in the clinic, is to get an idea of what's happening outside of the clinic visit. So even this afternoon, I saw a patient, I gave them some homework. So I actually give them a log to actually check their blood pressure readings, especially if I'm not sure if this is really masked hypertension or white coat hypertension. I'll have them check their blood pressure readings and send me the readings after 2 weeks of readings. So sustained hypertension is if you're having hypertension both in the office and at home. Normotensive, of course, is if you're having no hypertension in either setting. Masked hypertension is defined as no hypertension in the office, but hypertension outside of the visits. And white coat hypertension is hypertension in the office and normal blood pressure outside of the office. So, the last two categories is where I think really ambulatory blood pressure monitoring is very important, and it's very valuable in really identifying patients who are at risk. So what are some of the risk factors? So the relatively modifiable risk factors includes cigarette smoking, secondhand smoking, diabetes mellitus, dyslipidemia, overweight or obesity, physical inactivity, and also an unhealthy diet. Whereas relatively fixed risk factors includes patients with chronic kidney disease, patients who have had a family history of hypertension. This is especially important with secondary causes of hypertension. Increased age as we get older, or risk for hypertension will increase. And also low socioeconomic and educational status. Unfortunately, that has been tied positive correlation with risk of developing hypertension. Male sex, as well as other causes such as obstructive sleep apnea and psychosocial stress. So, when we're treating our patients, we also have to focus on these varying risk factors to assess and to really manage their disease. Now, the prevalence of hypertension is actually, it's very prevalent in African Americans, unfortunately. As we can see here, that with non-Hispanic Blacks, we're talking about a prevalence of 59% relative to other groups in the 40s, 44 to 47%. For women, the same is true. The prevalence is very high. And even for self-reported, antihypertensive medications, you can see here that the prevalence is very high. And this is why today's meeting is so important in terms of how can we address these disparities. So, over the past 15 years, the prevalence of hypertension has been highest in our group, but in the last 15 years, there has been some slight improvement. But what concerns me is that at the you can see here in the 2015 to 2018 period, you're seeing that there's a slight uptick here. So, I think, and I also do believe that if we were to expand this graph to 2022, we'd probably continue to see the same trend, because unfortunately with the COVID pandemic, a lot of patients have not been seeing their, medical providers often as they should. Some of them have not been taking their medications. Some people have lost their jobs. Economic difficulties may then cause them not to be able to afford some of their medications. So, we really have to keep our eye on this and really trying to treat our patients as best as we can. So in terms of differences in treatment for African Americans, generally speaking, the initial antihypertensive treatment should be a thiazide type diuretic or a calcium channel blocker. And 2 or more antihypertensive medications are recommended to achieve the blood pressure that's ideal of less than 130/80. And this is very important, especially in African American patients with hypertension. You may find that just one medication may not be effective in lowering the blood pressure. And, the goal should not be 140/90. The goal should be less than 130/80. So it's very important to remember that we're targeting that goal. So one of the things that can also help in having our patients achieve this goal is to have a medical regimen that will encourage compliance. Unfortunately, as many of these patients are young patients, they have 1, 2, sometimes even 3 jobs, and having to take a medication 3 times a day would be very, very difficult, even for some of us who who are in the field itself. So I think really trying to simplify the regimen is very important. So if you can choose a regimen that's once a day or at most twice a day, combination pills are very useful in this regard as well. So if the patient has been on medication, let's say lisinopril and hydrochlorothiazide for quite a while, the blood pressure has been well controlled, but they're having difficulty remembering to take the 2 tablets, then there are combinations that actually have the 2 tablets into 1 pill, and then that will allow them to easily take the medication in a more regular fashion. So simple things like that is also very important. Now, lifestyle modification is absolutely important, and I think this is a piece that most often is forgotten. So it's not just putting the patient on the medication and then having them come back in a few weeks. You really have to counsel them on looking to see what are some of the social habits that these patients have that's contributing to their hypertension. I have found that obstructive sleep apnea oftentimes is an undiagnosed issue, and this can also very much contribute to very difficult to control hypertension. So asking about sleeping habits, asking about tobacco smoking, for patients who are overweight, encouraging them to start an exercise program, to also modify their diet, and definitely alcohol intake. Again, with the pandemic, a lot of habits resurfaced for some patients. Even within the last month, I met a few patients who actually had stopped smoking, but with the pandemic went back to smoking and drinking. So trying to really address those lifestyle habits. Sodium intake, very important in African Americans, for all patients, but particularly so for African Americans because they're very sensitive to sodium. So you really have to encourage these patients to really watch the salt that they're adding to their meals and to encourage them to eat low sodium meals. Fruits and vegetables, high potassium meals are very important in these patients to manage their hypertension as well. So in terms of community-based interventions, which has worked in these patients, so I think one of the silver linings that was associated with the pandemic is that more of us have become comfortable, and patients have somewhat become comfortable with telehealth visits. I still use it for some patients, especially for patients who may live, where we are at the borough. It's a very rural part of the state, and sometimes patients may have to drive an hour and a half to come to the clinic. And if it's just a matter of getting blood pressure checked, really making sure they're taking their medications, having a two-week check-in with your patients can be very helpful. Sometimes if you have mid-level staff that can help you with this, an advanced practice nurse that can help in terms of having these telehealth meetings, especially when you're just starting the patient on the medication, because sometimes what will happen, you prescribe the medication, it's causing adverse effects for the patient. They don't call you, and then they decide to stop the medication. And then you come back, you see them in 3 months, the blood pressure is high. They're telling you at that point that they had stopped it 2 months ago. I mean, that's not helping the patient. So really having that check-in is very important. Web-based educations can also be helpful. As I mentioned before, home blood pressure monitoring, having a medication management application that can set reminders for the patients to take their medications, simplifying their medications. And as I mentioned, nurse counseling for those telehealth visits can be very helpful. Now, this has actually been studied in African Americans. There's a barbershop study and the church faith-based approaches that I think we'll be speaking about in the Q&A session that have actually been shown to be useful. With the barbershop study that had focused on African American males, where the intervention had occurred where they currently go to get their hair trimmed and stuff, and barbers were equipped with the information that they needed to educate the patients on the importance of taking their medications and really adopting healthy habits. The same is true for church faith based approaches that has also been studied and has been shown to be very helpful in this patient population in encouraging compliance. So in terms of, for women versus men and awareness and treatment. So a lot of our patients are aware of hypertension being an issue, and to some degree, less of a degree, the importance of treatment. But I think where things fall off is the control of these patients' blood pressure. And it's very challenging for the reasons that I had mentioned before. And I think this is where we really have to do a lot of work in this patient group. If you can see here in African Americans and also in Hispanics, that the control among males in this population is actually very low. And the same is true for also non-Hispanic Asians. So a lot of work to be done in this space, both from a provider perspective and raising awareness, and also helping to equip the patients in being compliant with their medications. So in terms of, what are some of the reasons that we're seeing these racial disparities? Non-Hispanic Blacks have been shown to have higher nocturnal blood pressures and less circadian dipping compared to their non-Hispanic white counterparts. In a 15-year longitudinal study that had involved young adults, showed that in non-Hispanic Blacks, that the nocturnal blood pressure dipping is reduced by the age of 10, and with an increased rate of blunted dipper response that commences during adolescence. So it's never too early to start, telling our children and teaching them healthy habits, because you can see that if unhealthy habits are started as early as age 10, it can start to have an effect that will manifest later on in these individuals' lives in their adulthood. So these data support the mounting evidence of early onset and rapid acceleration of vascular changes in these patients as well. And this has been associated with an increased risk of cardiovascular disease. The trend for reduced nocturnal dipping in these patients is not seen in individuals of African heritage residing outside of the US. So there's a suggestion that there's an interplay of both genetic and environmental interactions that might be leading to this trend. So I think this is still an area of research that we still have to look into what are the causes of this, for these patients. Variability in sodium retention and nocturnal blood pressure, as well as social factors, as I mentioned, can also has been hypothesized to explain the differences in blood pressure rates and control between ethnic groups as well. Body mass index disparities exist among the racial groups, and obesity has been tied with hypertension. So very important that we also adjust and really get these patients to achieve a healthy weight. And it was also found that BMI, the mean BMI for African Americans, is generally higher compared to their other counterparts during both childhood and continues through adolescence in both men and women. So again, just going back that, starting early in these patients, and when you're taking care of your patient, then asking about the family's diet and lifestyle can also be helpful. Some of my patients will actually have their children or their adolescent children accompany them to the visit, and really extending that education to not just the patient, but the family as well is so important. Long-term hypokalemia has been correlating with development of hypertension and also arrhythmias. And in the ARIC study, a statistically significant association was discovered between ethnicity and unprovoked hypokalemia. And it's actually more prevalent in non-Hispanic Blacks and in fully adjusted models of association. One of the areas I think in terms of causes for hypertension that is sometimes overlooked is hyperaldosteronism. There's primary hyperaldosteronism where you actually have an adrenal tumor that's releasing that hormone versus secondary hyperaldosteronism. And if you're seeing patients in the clinic where they're very difficult to control blood pressure and their potassium level is consistently low, even just being like a potassium of 3 on hydrochlorothiazide or 12.5, that's not normal, right? And you put in the patient on potassium and they're still having a low potassium. In those patients, you really should screen for hypoaldosteronism because you'd be surprised how many of our patients actually have this. And referring these patients to an endocrinologist if you're not sure. And in some patients, they respond very well to spironolactone for some of these patients. So there's something to consider in this group as well. So causes and potential solutions. So I did touch upon genetic and social factors. There's also variable medication response and adherence to medications, and suboptimal risk stratification tools. And this is a space that is very rich for research. There are a lot of unknowns in this space in terms of what are the best risk stratification tools to be used in these patients. Do we use the ASCVD risk tool that we use, or do we use another tool? And developing novel culturally specific treatment strategies can be very helpful. I did touch on that in terms of the barbershop study, the faith-based study as well. And then research is an area that's lacking in this space. So really having research that's focused on these varying ethnicities and focusing on these underrepresented populations would be very helpful in helping us to find out the reasons for these disparities and how they can be best addressed. So hypertension is a silent killer. So it's not just treating a number and getting the number lower. We're actually benefiting our patients when we're getting the blood pressure lower. African Americans have a very high incidence and prevalence of strokes, heart failure, AFib, and coronary heart disease. And lowering these patients' blood pressure can decrease their risk tremendously for these diseases, which can have a huge impact on improving their chances and of survival. So in summary, blood pressure should be categorized as normal, elevated, or stage 1 or 2 levels of hypertension. And blood pressure should be high blood pressure should be defined based on 2 separate careful readings on 2 separate occasions. There's several risk factors for hypertension. Some are modifiable, some are not. Risk factors to also remember is obstructive sleep apnea, sedentary lifestyle, obesity. And the prevalence of this disease is highest in non-Hispanic African American men, followed by non-Hispanic African American women. And over the past 15 years, although the prevalence had decreased initially, it is slightly upon the increase most recently. In these patients with hypertension but without heart failure or chronic kidney disease, including those with diabetes, an initial choice is thiazide type diuretic or calcium channel blockers. And don't forget that the goal of the blood pressure is less than 130/80, and oftentimes these patients may require 2 or more medications to achieve this goal. And in terms of blood pressure control, there's a lot of work to be done in this space. This is where we're really not hitting the mark. And there are interactions between genetic, social factors, as well as very differences in cultural factors that are contributing to these disparities. And finally, hypertension is a silent killer, and it increases the risk of many other cardiovascular diseases, including stroke, heart failure, AFib, and coronary heart disease. And I thank you very much for your attention.
Thank you, Dr. Palmer. It was a great presentation. At this time, I'd like to welcome Dr. Bolzia.
Thank you so much. I'm just going to pull up my screen. Can everyone see that okay?
Yeah, you're good. You're good, Claire.
Oh, good. Oh, thank you, because I'm a little new at this. Okay. So again, I'd like to thank Dr. Fishberg for inviting me to participate this evening along with our esteemed panel, including Dr. Williams, Dr. Washington, and Dr. Feldman. And a big thank you to Chanel Roberts for organizing this evening for us. She made things very, very easy to follow. So my talk is about risk factors in women's cardiovascular health and racial disparities in pregnancy outcomes. So I'm going to start on a somber note, but hopefully end on a more positive one. Are my slides advancing? Because all I can see is myself.
Yes, Claire.
Great, thanks. So we're going to talk throughout this period about maternal mortality rate, and I'll just shorten that to MMR. Basically, we'll be talking about pregnancy, specifically pregnancy-related maternal mortality rates. So that's defined as a maternal, as a death of a woman while pregnant or within a year of completed pregnancy, while excluding accidental or incidental causes. So I'm going to start with the global view, then we're going to move down to the national view, and then look at what's happening locally in New Jersey. So maternal mortality rates defined as a number per 100,000 live births. So I retrieved this information from the Gates Foundation, demonstrating that in 2018, globally, the maternal mortality rate was approximately 139 deaths per 100,000 births. Where do we fall within that large splay of maternal mortality rates? This data is from 2019. In the center here, you can see the United States, which currently is not at 14 deaths per 100,000, but in 2020 was 24 deaths per 100,000. And we are the only industrialized nation whose MMR is rising. We would at this time of this publication, we would have been placed internationally in 55th place among all nations, and you can see that our Haitian and Nigerian mothers are suffering from severe maternal mortality rates. So again, in the U.S., we are the only industrialized nation with an increasing MMR. This has been so since 1987, and as of 2020, this represented 23.8 or close to 24 maternal deaths per 100,000 live births. In that same year, in 2020, the maternal mortality rate for non-Hispanic Black women was staggering at 55.3 deaths per 100,000 live births, which is 2.9 times the rate of non-Hispanic white women. This is just another depiction of this alarming statistic, which also shows us in blue, green, and maroon here, the trend throughout 2018 to 2020. And we can see on the left here the total deaths per 100,000 live births in the US, and then broken down by race, ethnicity. And we see that non-Hispanic Black women are having an alarming rise in maternal mortality rate. How are women dying in childbirth? This is a busy slide, but I just want to focus on a couple of elements here. These are the 10 categorized reasons why that are placed on death certificates to describe pregnancy-related deaths. The various colored lines, horizontal lines, are telling you when these deaths are occurring during the pregnancy, on the day of delivery, or postpartum. Cardiac conditions down below correspond to somewhere between 50 to 55% of all deaths, pregnancy-related deaths. And what really strikes me from this review is how many of those cardiac deaths occur in the postpartum period. Mind you, women are covered for the most part until 60 days postpartum for their after postpartum care, not through the 1 year. And I think this is something that should be a major thrust and is of legislation. Okay, so where are we in New Jersey? This data comes from 2018, but here on the left is listed all of the states from in ascending order of severity of maternal mortality rate. The average here was a little over 20 deaths per 100,000 births. And where are we in New Jersey? Right up there, fourth highest in the nation. For we nearly double, we basically double the maternal mortality rate currently at, as I'll show you here, 41.7 per 100,000 live births. So I wanted to bring your attention to a new tool that has recently become available and was described in perinatal medicine, the journal of Perinatal Medicine in February of this year. It's an interactive tool, and I've just taken a clip of it to show you, in which you can go onto this website. It's called the New Jersey Maternal Mortality Dashboard, and it is broken up by county to show you where the hot spots are of maternal mortality. Additionally, the overlay shows blue dots where hospitals are, where women are delivering. So what's particularly, and so if we were in the website, I could hover over any county and it would show how many women delivered in that year and how many died. It's not only just useful to understand where women are dying and how we can allocate resources, but this overlay that I'm showing to the right, this tool actually allows you to look at multiple social determinants of health and compare those social determinants to the actual maternal mortality that you're seeing county by county. So I just picked up two examples to show you. The first is the percent poverty by county, and you can see a very strong correlation with poverty and access to care and maternal mortality rate. This is a similar graphic just showing you the percent of females covered by Medicaid by county. So you can see that the underinsured are also dealing with higher maternal mortality rates. Another way of looking at this was described in this clinical obstetric journal, in which 40 hospitals were ranked from their lowest maternal morbidity to highest at 40. And what you can see here is non-Hispanic Black women deliver more commonly in hospitals that are experiencing higher maternal morbidity rates than non-Hispanic white delivering women. So overall maternity, why are overall mortality rates in the US thought to be higher? Well, women are older on average at age of conception. That adds risk. They have more comorbidities that unfortunately are disproportionately present in Black mothers, including gestational hypertension, chronic hypertension affecting pregnancy, obesity, poor physical activity, unhealthy eating habits, and constant societal stress, which cannot be underemphasized. So focusing on social determinants of health, we underestimate how important that those are in our overall health. So social determinants of health can make up to 60% of our health outcome. And these social determinants include where you're born, where you grow up, where you live, where you work, and age, and includes your socioeconomic status, your education level, your physical environment, the neighborhood you're growing up in and working in, our employment, social support networks that are available or not available to us, and again, access to healthcare, which we looked at previously. In addition to this complexity, and again, we find, unfortunately, that Black women in America have experienced more deaths, the most deaths from maternal mortality. So even though Black women comprise 13% of the Black Americans, I'm sorry, make up just 13% of the population, the mortality rate is approximate for women, pregnant women who are African American is 1/3. So overrepresented in risk during pregnancy. Again, carrying about a 3 to 4-fold higher risk of pregnancy-related death than non-Hispanic white women. How can we improve the maternal mortality rate in New Jersey? Well, here's my plug for cardio obstetrics and multidisciplinary care. So that's why I like my job a lot, is that there is a lot we can do by working with identifying high-risk women and working in a multidisciplinary manner. So this includes referral for preconceptual health evaluation with, for instance, cardiology, maternal fetal medicine, and genetics. Monitoring, intrapartum monitoring of blood pressure during pregnancy. So there's an extra set of eyes, in addition to our obstetric colleagues, watching blood pressures and managing it. What's been particularly helpful, I think, at Morristown is that we have a multidisciplinary team who meets quarterly, comprised of the OB anesthesiology chair, a cardiologist, the patient's obstetricians, the maternal fetal medicine, our maternal fetal medicine colleagues, and we determine a birth plan. What should be the mode of delivery that is safest for mom, and what are her particular risks? This birth plan is then published in the patient's medical record, so that when she arrives on labor and delivery, no matter what team of providers is assisting her, everyone has access to her birth plan. The other thing that we can't ignore, again, is this concept of postpartum management and trying to lengthen the amount of time that we can provide care to women. I think Dr. Palmer mentioned telemedicine as now a viable option that we as providers have become comfortable with and can utilize to better monitor women postpartum, when sadly up to 1/3 of maternal deaths occur. Ways to improve, again, preconception counseling, community outreach programs. I was also struck by the barbershop study that Dr. Palmer mentioned for the intervention for Black men with hypertension. Here at Atlantic Health, one of the initiatives that I and Dr. Coughlin trialed was nail salon outreach. So we brought women of color who had experienced preeclampsia in their during their pregnancy come to like a light dinner gathering in their local nail salon and spoke of their experiences. Many of the women told me that they had no idea that there were significant cardiovascular complications that were so commonly occurring during pregnancy. So it's one thought of hair salons and nail salons might be the way to reach women. Faith-based community outreach was discussed. Acknowledging Black mothers' concerns, not just being a better listener, working on cultural competency, and diversifying the physician workforce so that more healthcare providers look like and have common cultural backgrounds to the patients we care for. Removing those postpartum care barriers that we talked about with, which include transportation to doctor's appointments once you have a newborn, childcare of that newborn, and the costs of repeated doctor's appointments that may be mitigated somewhat by providing home blood pressure monitors. Interestingly, I think our OB division here has a home blood pressure monitoring remote program working. Perhaps Dr. Lauder could speak to that later in the program. But that could potentially allow us to help these women, particularly in the postpartum period. How else can we improve? Social support on a local and national level to combat systemic racism and implicit bias and recognizing it within ourselves. Extending postpartum care, I keep repeating that, for up to 1 year could make a big difference, as 33% of overall maternal mortality occurs in the postpartum period. And finally, this is a slide that always reminds me that these difficult times in pregnancy are actually an opportunity to help women. So pregnancy is a vascular stress test. Our blood volume rises by 40%. We have to increase our cardiac output, and we also have to vasodilate to accommodate that increased cardiac output. In the blue here, you can see women who don't have vascular or metabolic disease may have perturbations or changes in their vascular reactivity, but ultimately develop cardiovascular disease at a later point, whereas women who experience in the red, who experience either a preeclamptic or a gestational hypertensive pregnancy, are telling us something, that they're at much higher risk of following this trajectory of developing manifest cardiovascular disease earlier in life. So it's really an opportunity to not let women forget what happened to them during that pregnancy. I always ask women, did you, it doesn't matter if they're menopausal, did you have a preeclamptic pregnancy, or did you have complications? Did you have gestational diabetes? Those things become really relevant in her future cardiovascular risk assessment. So with that, I just want to thank everyone for your attention, and that's it for me. I'll pass it on to Dr. Fishberg.
Thank you, Dr.
Just before,
Oh, go ahead, Dr. Williams. Yep.
Yeah, just before Dr. Fishberg gets on, I just want to know that we do see the questions in the chat. We're keeping track of them, and I think we have a really impactful discussion, towards the end. So if you can sit tight with your questions, go ahead and put them in as they come up, and we'll definitely make sure we address them right after Dr. Fishberg's presentation. Thanks.
Have I unshared? Good. Okay, I have.
Yes, you're okay.
Rob, you're showing your Epic screen.
Oh, no, that's okay. Let me.
We see your presentation.
Okay, great. So I'm going to be talking about uh, disparities with hypercholesterolemia, and most of these, many of these slides we come directly from the Family Heart Foundation. Used to be the FH Foundation, and my main disclosure here is I am an investigator in the Cascade FH Registry, which is a national registry involving 40 sites. And right now we have over 6,000 patients enrolled. So it's probably the largest registry of patients with familial hypercholesterolemia. And just as I'm not going to discuss what it is exactly, but familial hypercholesterolemia is generally a monogenetic disorder involving mutations in either APO and ApoB, LDL, or PCSK9. Most of them have to do with the LDL receptor. But again, with the FH Foundation, we're interested in looking at hidden risk factors, and actually now they're all not only interested in FH, they're also interested in LPA. So again, the guidelines of treatment of FH and ASCVD is in patients with very high-risk patients. We're looking for an LDL threshold of 70 milligrams per deciliter. And at that point, if it's over that, consider the addition of non-statins to statins, which is usually Zetia, now maybe bempedoic acid, and also PCSK9 inhibitors. And in patients, and that's for patients with high-risk ASCVD, for patients with severe primary hypercholesterolemia, which is generally FH. Hold on, let me just go back to this. It's patients who have LDLs above 100, adding ezetimibe or PCSK9. But just as perspective, if you look, and this is an assessment that they did in our area, we think there could be close to 20,000 FH individuals within 30 miles of Atlantic Health System, and these are often undiagnosed. And one of the things that we've been doing, one of the reasons myself and Dr. Feldman have the lipid work group is we're trying to find a way to uncover these patients. And we actually have a registry of patients with LDLs over 160, where we're trying to find these patients and also hopefully cascade screen their families. Now, with everything else, there are inequities in achieving LDL goals. And I think that in this one case, there's a big difference between men and women achieving LDLs less than 70 or LDLs less than 100. And this is a persistent difference between the sexes. And we actually started looking at this in Atlantic Medical Group, and we did find a big discrepancy in AMG, similar to this. Again, we went through the data. I was going to present some of that, but it's still very preliminary. But it's enough to say, suffice to say that this discrepancy has been seen in every evaluation of LDL. And again, the difference is pronounced whether you're looking at less than 70 or less than 100. And I think that if you look at people, there's also not only in treatment, but also patients getting high intensity statins. And we'll discuss this a little more. Why are men more likely to get this than women? And there's a few reasons, which are some are obvious, some are not quite as obvious. So women are 40% less likely to be on a statin, including a high intensity statin, compared to men. And this is across the board. And unfortunately, this discrepancy is even more pronounced when we look at African Americans and Asian populations. And again, European ancestry, there's much greater success in achieving LDL compared to Asian and African American Blacks. And again, particularly, I don't have this slide, but African American women are particularly at risk here. And again, looking at treatment of FH in the US, there's significant ethnic and racial inequities. When we look at whites compared to Blacks, and again, this is pre-treatment, and these are patients with familial hypercholesterolemia. And again, there's many more patients in this registry, whites compared to Blacks and Asians, but I think these numbers hold out at Hispanics, that the achieved LDL is much more robust among whites compared to Blacks and Asians and actually and Hispanics. So it's a significant difference. Now, one of the things we're concerned about is not only is receiving statins, but also PCSK9s. And this is also an area that has been looked at, and it appears that there are effects of access to prescribed PCSK9 inhibitors and cardiovascular outcomes. Again, if we think that achieving an LDL less than 70 is important, that there is significant differences here. And what we found is that women, minorities, and individuals with low incomes were more likely to have rejected unfulfilled PCSK9 prescriptions. Again, a number of reasons for this. One of the reasons might be the cost. I mean, the unfilled prescriptions often have a higher copay. And again, one of the problems with these drugs, they're very expensive, and the copays could be high. We look at this is looking at the use of statin, ezetimibe, PCSK9 inhibitors use in claims data, and again looking at all these groups between, again, these are patients who are maximally treated on 3 agents, and again it's much more men much more than women, and ethnic categories, African American, Hispanics, Caucasians. And it actually also goes across education levels and income levels. So there's multiple areas where we see discrepancy in the use. Again, we looked through the data for Atlantic, and there's a huge discrepancy, particularly among African Americans in receiving PCSK9s. I'm sure that this, when we look at use in the family practice clinic or in the internal medicine clinics, there's very little use of PCSK9 inhibitors, even though these are patients often at particularly high risk. When we look at vulnerabilities, and the more vulnerabilities you have, the less likely you're going to have statin use. So again, if you look at age, an older age group, female, African Americans, low income, and actually poor health insurance. Poor health insurance is a very significant risk. I think we see this with a Medicaid patient versus even Medicare, or even some of the less robust companies. And we find this daily, trying to get particularly PCSK9 agents improved. It's almost impossible to get it improved with some of these insurances. Now, one thing I do want to talk about is, again, this part of the talk I'm going to, hopefully we'll catch up, so we'll have more time for questions, is looking at gender differences. And this is it's a lot we could talk about here. One thing I don't have on this slide is looking at young women. And I think there's a bias against treating younger women with statins, particularly, again, women of childbearing age, teenagers, because of potentially interfering with estrogen. And there's a real bias against treating them because they potential made for pregnancy. And patients with FH who do become pregnant, again, there's a big gap for treating. And one thing we know is that when it comes for FH, the earlier to treat, the better. And there's been studies looking at treating teenagers. And if you could treat teenagers who have familial hypercholesterolemia with the statin, you can actually prevent development of disease. So again, there's a bias against treating women at an early age and as adolescents or as young adults because of various, whether it's because you think that they're developing, because you think the potential childbearing. And I think there's a burden if you wait till someone is post-childbearing in order to start treatment. Again, we know from genetic studies that the longer you treat someone, the less likely they are to having developing disease. The other thing this study showed, this is a study looking at gender differences in side effects and attitudes regarding statin use, is that women were likely to stop a statin in men because of muscle symptoms. Women were less likely than men to be prescribed a non-statin lipid-lowering drug. Women were more dissatisfied with their cholesterol treatment than men, and women were less compliant with their statin than men. The other thing is, at an early age, men may present with a heart attack, clear angina, while women may present more with diabetes, but these women still are at high risk. And we've seen this, that women also, it's hard to get a statin prescribed. I know this because their risk level is lower. So it's hard to convince an insurance company to get appropriate testing or appropriate medication, even though they're still at high risk of having a heart attack. And finally, I'm going to talk about discrepancies when it comes to racial and ethnic populations. And this actually will mimic what was discussed in the other groups, that there's multiple factors that would explain why, particularly the African-American population is at high risk. Again, we talked before about low socioeconomic status, income, education, environments, lower income, lower education appears to put patients at higher risk, and less access. There is structural inequities, discrimination, racism, chronic and toxic stress. Again, we're talking about chronic and toxic stress being important in this population. A lack of access to primary and specialty healthcare insurance. We see this during COVID, that it's harder to access to specialties of primary. And again, you may have these patients more likely to have uninsured, poor insurance, or Medicaid, and again, less access to these classes of medications. There's also cultural eating habits, patterns, food desserts. And again, there is some suspicion about the medical community. And I do think, with reflected before, we do need more physicians who look like the patients, more providers that look like the patients, increase in comfort level. I think the barbershops and nail salons sound very interesting. Again, we have to find ways of reaching these patients. And finally, there is some unique genetic aspects, lipid profile, statin response. Don't forget, most of the trials we've done have often been in Europeans, communities, and most trials are unrepresented in the African American or even the Asian community. So when we look at these medications, the effectiveness of them, we don't have as much information. And also when it comes to genetics, there may be some unique genetic aspects, particularly in the non-Hispanic Black and also in the South Asian group. And finally, this is an area which I'm very interested in, elevated lipoprotein A. This is something that we do see in South Asians. And also non-Hispanic Blacks do have higher LPA levels than other groups. So I think all these things together, I think we need to consider. So that's the end of my talk. I think we could go on to the panel discussion now.
Oh, thank you. Thank you. So I'm going to start with Dr. Weisbrot had a lot of questions that he put into the chat. And I think that Claire actually answered a lot of them. We tried to do as many as we could. But we did want to start with one of the questions he had about treatment, and wondering, Renee, if you could handle that for us. Like, what medications would you start in African Americans? What's your cocktail?
Right. So my first choice usually is a medication that's once a day, and I tend to start with a calcium channel blocker. If the patient's blood pressure is like stage 2, then I will try both a calcium channel blocker and a thiazide diuretic. So that's usually my first choice. If the patient is diabetic, although the guidelines have actually, in the past for diabetic patients, we were putting these patients on ACE and R, but the latest guidelines actually have not specified that. But I tend to still use it for my diabetic patients if they're African American, to lean more towards an ACE or an R, especially if they have proteinuria. Proteinuria, for sure, you should be using those.
Great, thank you. And Carlene, did you want to start with your questions?
No, sure. Thanks for that. And, just listening to everyone, tonight, I just feel like it's so much information I'm going to leave with tonight. Like Dr. Bullock started off talking about the prevalence of hypertension, and that it's particularly high in women of color. And of course, the control is poor in that group. Dr. Baccia told us about, the increasing maternal mortality rates in women in our country, and how those rates are disproportionately high for women of color. And specifically what I loved about it was that how these rates are related to those social determinants of health. And of course, Dr. Fishberg's followed up, really, I think, showing us the data that supports that, there are ethnic and racial inequities in achieving those LDL goals, receiving statins, access to PCSK9. And I guess what I want to say is this, we all want to kind of jump on this problem and really attack this problem on how we can close these care gaps and really address these disparities. But this problem seems so much bigger than who we are. And I keep going back to, tonight is a first step, and it's all about education and really about what can we do differently in our practice. So given that the first step is education, I want to review some of the questions that came up in our pre-session survey. I don't know, Chanel, if you can kind of pull up the first questions, and Dr. Feldman, if you can help us and guide us through these, questions. I think it'll be a great way to generate our discussion. I believe the first question was, what is the greatest cause of strokes in African American patients? And Chanel, do you want people just answering directly into the chat?
So while you're doing that,
Yes, please answer directly into the chat. Can everyone see the question?
No, I can't. It's that in the lower panel. Oh, I'm seeing it. So are we to answer the?
Type in your response. This is via word cloud.
Oh.
Yes.
Okay.
Chanel, while you're doing and trying to fight technology, and you can see I failed if you look at my background. This program is just amazing. It brings together, things that we think we know, but we have to be reminded. And I thank you, Dr. Williams. And it's the beginning of a start. One of the things that is common to all the programs is we as providers or clinicians have to go out and bring these high-risk patients, and not bring them to us, but we have to go out in the community. Because one of the things that struck me is after a young mother delivers a baby, they got to do postpartum care, particularly if they're high risk, but then they have the baby to take care of. Now, how do we do that? Telehealth can help a little, but we got to go out into the community and be there, particularly for our high risk patients. The other theme that comes across is we need providers that look more like our patients. And when we look at providers, it doesn't have to be a doctor. The barbershop and the nail salon, they while the doctors were in the background, they were pharmacists, nurses, and everything else. So that's a way to get in. And I was was on a program, and they addressed some of the questions that we're going to answer about resistant hypertension and the high risk of strokes. And the thing is, if we're in the community level, we're there, and the reason there's such severe hypertension at a young age, and the first question is, at what age do you start to monitor? Well, if your parents are hypertensive, then it's never too early to check your blood pressure, particularly if you're Afro-American, and particularly if the obesity and the diet is creeping in. And so, that's really, really very important is to look at the patient and the family you're dealing with. It's more than just cascade screening for LDL, but it's also family history of hypertension. And as pointed out, the history of preeclampsia, hypertension, gestational diabetes, which carries over into the 30s and 40s. So I think this program is eye-opening, and we have a lot of work to do once again.
Did you want to comment on the third question, Dr. Feldman, about the definition of resistant hypertension? This was one question where there was a widespread of the answers.
Okay.
Do you want to talk a little bit about resistant hypertension?
I've had an eye-opening with that in some of my recent training. Resistant hypertension to cardiologists or nephrologists is a blood pressure that's elevated 140 to 150 when the patients are already on 3 medicines. So there may be on an ACE, an ARB, and the third medicine, an ACE and or an ARB or CCB, and the third medicine is a diuretic. And it turns out that a lot of this can be dealt with in home blood pressure monitoring. And we really encourage home blood pressure monitoring, and Dr. Palmer covered mask hypertension, white coat hypertension. And one of the things I learned, because every patient that comes in, 10 or 15%, says, I have white coat hypertension. And what I learned in the last few weeks is, as these patients get older, white coat hypertension actually turns into hypertension. So these patients have to be monitored. And you just don't let them get away with the white coat. And the way you do that is home blood pressure monitoring. The other thing I recently learned is everybody uses these wrist monitors. They're worthless. So a monitor at the arm with proper technique for $30 or $40, and write it down various times during the day. So resistant hypertension, you have to work through all of that. But and then you're hoping that the patient is taking their medications correctly. And so we would want to use, and Dr. Palmer, I think it was, said more than one, a thiazide type diuretic. So to us, in most people, a thiazide type diuretic is hydrochlorothiazide, but that is not what the hypertension specialists recommend. And all the studies done in the 80s and 90s were not done with hydrochlorothiazide. It was done with a drug called chlorothalidone, which is it's a thiazide, but it's a thiazide diuretic, has a 24-hour level of activity. It can be used in chronic kidney disease. It was just studied in people with an EGFR in the 20s and 30s, and it's very, very helpful. So chlorothalidone, it comes, unfortunately, 25 milligrams, and some people can get away with 12.5. And then there's another drug which we don't use at all, but is studied in Britain, indapamide, which is another very potent agent. So if a patient's blood pressure is high and they're on like lisinopril with hydrochlorothiazide, the first thing is to separate out the hydrochlorothiazide, put in the chlorothalidone, and continue the lisinopril with chlorothalidone, and then add in, your CCB, and the one they recommend, the long-acting, is obviously amlodipine. And then if you're still not controlled and the patients are taking their blood pressure at home, they have resistant hypertension, and you can use spironolactone, a mineralocorticoid receptor. Dr. Palmer, would you comment on that, please? Because you're shaking your head.
Yes, absolutely. Because I can tell you that I've had success with indapamide and chlorthalidone, and the patients that I have leaned more towards that. One of the things I'd caution the group is watch out for hypokalemia, because it can, it can really get that potassium low. So I tend to attach it to potassium as well. But those are really great points. Thanks.
Thank
Jeff,
you.
it's interesting, right? Dr. Palmer made really good points in her talk about the idea of, right, initially starting with combination medicines. And one of the things that's, right, somewhat frustrating is chlorthalidone is probably a better antihypertensive than hydrochlorothiazide, yet the combination medicines with chlorthalidone are, I think there's one, but are very, very limited, hard to find and hard to use. And it's unfortunate, because I think that might be part of the reason why a lot of us choose hydrochlorothiazide based, is we combine it with calcium channel blockers or ARBs, because those are the combinations available, when we know chlorthalidone probably is better, and like you do, often change to it in the setting of running into resistance. But goodness, it seems like it would be better to start there.
Josh,
I agree.
let me answer that. This is an example of good old American pharma intuition. So if you look at the drugs that have combination ACEs or ARBs, whether it be with Novartis or Merck, they don't have chlorthalidone in their armamentarium, in their toolbox. They only have hydrochlorothiazide, and all they care about is selling drugs. So you go back to the original studies, you go back to all the studies, they were all done with chlorthalidone. None of them were done with hydrochlorothiazide. None of them.
I'm dating myself, but I do remember that. And I did want to ask a question of Claire, and this is regarding something that we really need to take better histories, especially in our women of color, and getting those maternal histories and making sure that we understand even family history. Can you speak to that? Because I know that in the Women's Heart Institute, you do a really excellent job of doing that.
Well, thank you. So we know that women who have experienced gestational diabetes have a 7-fold higher risk than those who don't of developing diabetes in the next 5 to 10 years. And similarly with preeclamptic pregnancies, there are risks, long-term risks, not only to the woman, but to her child, the child of it. So it's relevant to ask a woman or a man if they are the product of a preeclamptic pregnancy, or any pregnancy complications that they know of. So yeah, just I kind of just have a macro that I use in my history taking, where at the end of it, it just says gyne history. And if it's all negative, I have a little macro, no preeclampsia, gestational diabetes, or eclampsia. And if not, I fill in what the complications were, because it does heighten your index of suspicion.
I agree. Jeff?
Judy, can I say, we'll make
Yeah.
one comment? I think that listening to, and I think Renee and Claire, your presentations were fabulous. I think that one of the things as clinicians in AMG we need to have access to is that we're all very busy clinicians, but we're dealing with these some of these social determinants of care, whether it's with women with preeclampsia, hypertensive, high cholesterol, with limited time and resources. And we need somehow to have availability, whether it's nutritionists, whether it's social workers, whether it's PharmDs, and we need somehow to have that available to clinicians in our practice, similar to, Judy, what you have in your family practice clinic. So I think we need to somehow bring that into, and if we think that all these things will improve the care for our patients, I think that should be a priority for our healthcare system, to bring it to the level of the individual practitioner and the individual group.
Yeah. Thank you. Well, we're at 7:45, and I did put in the chat that Chanel will work her magic and will add additional CME credit for us. And I see that we really haven't lost many people. I do want to put in a plug before we start to lose people that April is Black Maternal Health Week, and April 7th to the 14th is that time, but it's the whole month. We are going to be doing some special programming here at Atlantic Health. We are presently working on it, Dr. Christina Johnson and our marketing department. And so you'll be seeing messages, and you'll be listening and seeing real stories from Black women who really even work here at Atlantic Health, and they are willing to share their stories with you. I do want to recognize time, but if there are any other questions, Carlene, if you wanted to, we can go ahead and do that.
No, I think we can follow up on the questions in the chat that came up. There was one regarding what were some of the cardiac causes of death in that postpartum period for Dr. Baccia. And I also wanted Dr. Fishberg and Dr. Baccia to address, statin use in women of childbearing age, because that also came up in the chat.
Let me make one quick comment about that. There's always been a thought that women who are in childbearing age cannot take statins. The newest recommendation is that they can continue the statin until the point they become pregnant. I think that's very important. That in the process, again, we talk to these women that may spend a few years in the process, but they could safely take the statin until they become pregnant and stop it at that point. Unfortunately, there's few options, during pregnancy at that point for lowering the cholesterol. Resins are probably the safest ones to take. But again, we do have few options after that. But at least up to the point they become pregnant, it is safe to take a statin.
I'll make a counter argument, Rob, and right, of course, in the spirit of Good Together, Claire and I have been discussing in the chat, and I think I do similar to what Claire suggested and did, right, with the new and probably old but newer written about idea that, right, LDL is kind of like smoking and is like pack years, right? Worse to have it for a long time, bad in FH because you have it for a really, really long time and really all your life. And if off medicine, even for a few years in childbearing age, with the possible risk associated with statin in pregnancies, especially if it's done in a, family planning sort of way, I don't think I'd I don't think I'd keep someone on a statin who I knew was trying to get pregnant. Actually, I know I wouldn't. What I would do is
the new recommendation has changed. There's changed that you can, but again, that's an individual decision. It is considered at this point, again, that they change the recommendation. Whether or not that's the right recommendation, I'm not sure, but there is a change in the package and so in the recommendation for statins.
No, and there's some written about keeping people on statins while pregnant, even.
Well, that I wouldn't.
I wouldn't either, but there's literature on it, and some in Europe who have written about it and done it. I don't know. I'm just saying, in terms of how I practice, I tend to take them off if they're trying to get pregnant at least 6 to 12 weeks ahead.
Josh, Renee has a comment she wants to make.
I think one of the I know we're not talking about imaging here, but one of the tools that I've used, especially for women or men too, when they're really trying to say does this patient need to be on a statin, is a calcium scoring. If their calcium score is 0, then you may have some time before having to consider statins for these patients, especially for a young person that's in childbearing age, I think.
Very good points.
Great. Well, I want to thank you all. And if there are no more questions, this is such a great discussion. And I think that looking at these issues, and also the fact that in In Atlantic Medical Group, we're also looking at closing our care gaps and looking at hypertension, statins in those patients with diagnosis of hypercholesterolemia, and we're really starting to take a look at that, because remember, equity in care actually equals quality in care, and it's closing those care gaps and ensuring that every patient gets the opportunity to be treated in an equitable way, and that is offering the medications that they should be on. And then a lot of the things that we're doing is working with our pharmacists to increase access for our patients to the drugs that they need. And so we really have a robust program. I want to thank you all tonight for being here. I think this was a great discussion, and we are going to have to do part 2 of this, I think, and really take a deeper dive into dealing with these issues. Thank you all so very much.
Thank you, and thank you to our esteemed panelists.
Thank you.
Dr. Washington and Dr. Palmer. Yes, I will make some adjustments to the CME. It will happen tomorrow. But again, I just want to thank you all, and be sure to log into your Highmarks to claim your CME credit tomorrow. Thank you.
Dr. Palmer, on behalf
to the barbershop study in the chat for those who might want to come.
Thank you.
Dr. Palmer, on behalf of Rob and I, AMG, welcome to our new family. It's great to have you for a second time.